and this is another concept in fluid and electrolytes. This one focuses on fluid and electrolyte imbalance. Just an overview. Fluid and electrolyte has factors that affect the ability to maintain fluid and electrolyte in the body. These can include illness such as vomiting, diarrhea, suctioning, diabetes, cancer, head injuries. Some of your trauma could be tissue trauma from burns or crush injuries. It could be related to surgery. Medications could be the cause. These are especially diuretics and corticosteroid. Fluid imbalances have two major types. One is isotonic imbalances. These occur when water and electrolytes are either lost or gained in equal proportions so that osmolality of the body fluids remains constant. Osmolar imbalances are when loss or gain of only water occur, so the serum osmolality is altered. Looking at fluid volume deficit and dehydration. Fluid volume deficit is a decrease in intravascular, interstitial, and/or intracellular fluid. Dehydration refers to loss of fluid alone. It is often used interchangeably with fluid volume deficit. However, they are quite different. Because remember, dehydration refers to the loss of pure water only without the corresponding loss of sodium, which is a fluid volume deficit. Looking at the pathophysiology and etiology, fluid volume deficit develops slowly or rapidly depending on the type of fluid loss. Isotonic fluid volume deficit refers to loss of electrolytes along with fluid. There are different types of imbalances, and isotonic dehydration is also called isonatremic dehydration. This is when fluid loss is not balanced by intake and losses of water and sodium are in proportion. This is common in vomiting and diarrhea. Hypotonic dehydration is also called hyponatremic dehydration. This is characterized by a change that is proportionately greater with loss of sodium than water. So they will have decreased serum sodium levels. This could be from prolonged vomiting and diarrhea, giving IV fluids with electrolytes as in treatment for dehydration. They are at increased risk for hypotonic dehydration with the infusion of those IV fluids that contain electrolytes. Your hypertonic dehydration is also called hypernatremic dehydration. This occurs when sodium loss is proportionately less than water loss, so they will have increased serum sodium levels. This could be from diabetes insipidus, giving IV fluids or tube feedings that have high electrolyte levels. Third spacing is when you have fluid shifts from vascular space to another area that is not available to support normal physiologic processes. So basically this area does not normally have fluid in it. This trapped fluid causes volume loss. It is not available to support those normal physiologic processes. Third spacing often occurs in the interstitial tissues, pleural or peritoneal space. Assessing the extent of fluid volume deficit is very difficult because there's no change in body weight. And so third spacing is difficult to assess because it may not be reflected in measurable data. The etiology is from excessive fluid loss. Most common is excessive loss of GI fluids from vomiting, diarrhea, GI suctioning, intestinal fistulas. It can also be from insufficient fluid intake or failure of regulatory mechanisms and fluid shifts within the body. Other types of fluid loss could be excessive renal losses of water and sodium from diuretic therapy, renal disorders, or endocrine disorders. It could be from heavy sweating, from excessive exercise, or increased environmental temperature. It could also be from hemorrhage or chronic abuse of laxatives and or enemas. Insufficient intake. This is from lack of access to fluids, inability to request or swallow fluids. It could be from oral trauma, an altered thirst mechanism, which a lot of times you'll see in the elderly. Excessive exercise during very hot weather with sufficient replacement. Burns is another cause of loss of fluids. Burns of the skin usually involve huge body losses of fluids, including water and electrolytes, particularly sodium. And because these serum proteins are lost, fluid is likely to leak into the interstitial spaces, causing edema and further contributing to fluid deficits. And that's what happens in burns, which we'll talk about more later. Fluid leaks into those interstitial spaces, like I said. Hypotonic dehydration is commonly seen in the initial periods after a burn. Children are more likely than adults to experience imbalance from exercise. They may not feel thirsty, so they fail to drink even when they're dehydrated. They have a higher body surface area and metabolic rate than adults. And so they gain more heat from the environment when it's hot, and they lose more heat when it's cold. They are more prone to vomiting and diarrhea. Overuse of diuretics, especially in adolescents with bulimia, is also a cause. Gastroenteritis caused by the rotavirus is also a cause. Radiant heat, which is also known as phototherapy, that is used to treat hyperbilirubinemia, increases their insensible loss of water through their skin. Their increased respirations normally causes an increase in that insensible loss from their lungs. Radiant heat can also be used in low birth weight infants to help maintain their heat, and so that is another risk as well. Older adults, they have fewer intracellular reserves, causing rapid development of dehydration. They have a blunted thirst perception, altered hormone response. This also contributes to dehydration. Changes in mentation, cognition, related to health status or adverse effects of medications. Lack of free access to fluids. They may be dependent on others. They may live in long-term care, or they're at home but still need help with their ADLs. Voluntary fluid restriction could be from fear of incontinence or the fact that they depend on others for toileting needs. Older adults are generally told to drink fluids even when they may not be thirsty, and that's to help prevent dehydration. Pregnant women, especially in their first trimester, they have morning sickness, so they have increased vomiting, which puts them at risk for dehydration. Also, blood loss during a miscarriage puts them at increased risk for a fluid volume deficit. They are told to avoid caffeine, alcohol, and diet drinks because they all increase diuresis, causing dehydration. And so this is just looking at dehydration, which is really this no water, no salt, or both. No water is dehydration, and then fluid volume deficit contains the salt and water. And so this is just kind of showing you some of the causes and what else may be going on as well as far as their other signs and symptoms. Clinical manifestations. Symptoms relate to the severity and degree of water loss. The initial symptom may only be thirst, which can progress to lethargy, dry mucous membranes, reduced urine output, weight loss. So it's important to do daily weights for those at risk, diminished skin turgor, and hypotension. Symptoms of hypovolemic shock. Need to be aware of those because if they lose lots of fluids, especially very rapidly, they can go into hypovolemic shock. Those symptoms are hypotension, tachycardia, tachypnea, decreased or absent urinary output, decreased cardiac output. If it's not, treatment is not started and initiated, this could lead to coma and death. Your fluid volume deficit is estimated by percentage of rapid weight loss. Loss of 2 to 5% of their total body weight is mild fluid volume deficit. Loss of 6 to 9% is moderate fluid volume deficit. And losses greater than 10% of that total body weight is classified as a severe fluid volume deficit. Other manifestations that you may see, poor skin turgor, which is hard to determine in elderly because they don't have good skin turgor anyway. But usually tongue turgor is not affected by age, so you can assess the tongue for size, dryness, and longitudinal furrows. Clinical manifestations in children. Mild dehydration a lot of times is hard to detect in pediatric population because they appear alert and have moist mucous membranes. Irritability and restlessness is often seen in infants. Thirst in older children. In moderate dehydration, you may see some lethargy and sleepiness, decreased skin turgor, dry mucous membranes. Urine may be diminished and dark in color. Increased pulse. They may have a normal or decreased blood pressure. In severe dehydration, you'll see seizure activity and decreased or absent urination. You will also see dry mucous membranes, poor skin turgor, rapid pulse, markedly decreased blood pressure, increased lethargy or unresponsiveness in severe dehydration. All right, clinical manifestations are more difficult to recognize in your older adults. Altered mental status, memory, attention may be an early sign of dehydration. Skin turgor less than reliable indicator. This is usually checked over the sternum or inner thigh because they may be more effective areas. Dry mucous membranes, dry tongue furrows. Chronic dehydration can cause itchy skin, brittle hair that is dull in appearance, and loss of thirst reflex. Diagnostic test. Your serum electrolyte panel, BUN and creatinine, and urine-specific gravity are useful in detecting moderate and severe dehydration. Clinical therapies. Adults usually require about 1,500 milliliters a day or approximately 30 milliliters per kilogram for their ideal body weight for maintenance as far as fluids go. Oral rehydration is the safest and most effective treatment for alert patients that are able to take in oral fluids. So for mild to moderate dehydration, water alone may be okay. If it's severe and when electrolytes are also lost, they will need carbohydrate and electrolyte solutions like sports drinks, ginger ale, or rehydrating solutions like Pedialyte or Rehydrolyte. For pediatric population, they recommend hydrating orally with 1 to 3 teaspoons of fluid every 10 to 15 minutes. Intravenous fluids are used when client cannot ingest fluids or if they have a severe deficit. They usually use isotonic solutions like lactated ringers or normal saline. Normal saline that's given very rapidly can precipitate acid-base balances because it does remain in the vascular compartment and increases blood volume. So a lot of times lactated ringers may be preferred to help expand plasma volume. D5W which is your 5% dextrose and water or half normal saline, can also be given to help provide water in treatment with total body water deficits. Because remember, dextrose and D5W, dextrose is metabolized, leaving only free water. And so, because it leaves free water, it does not provoke hemolysis of red blood cells. All right, looking at the nursing process. Under assessment, you need to get a good history. You need to get risk factors for fluid loss. That could be nausea and vomiting, nasogastric suctioning, increased urinary output, fever, wounds that are draining. Medications are also a risk factor. Renal and endocrine diseases are risk factors. Any precipitating factors such as being in hot weather. You also want to address other precipitating factors like exercise, lack of access to fluids, any recent illness, especially if they've had a fever with or without vomiting and diarrhea. Also want to get a history of onset and duration of their symptoms. In physical assessment, you want to assess their weight, their vital signs to include orthostatic blood pressures and pulses. Peripheral pulses and capillary refill need to be assessed. Assess for any jugular vein distension. Assess their skin for color, temperature, and turgor. Assessing level of consciousness and mentation, and also assessing their urinary output. A potential complication of fluid volume deficit is hypovolemic shock. And so this kind of gives you an idea of some of the causes for hypovolemic shock and gives you also some of your symptoms. All right, so these are your NANDA diagnoses for fluid volume deficit and dehydration. In planning, goals for adults may include that the client will achieve fluid and electrolyte balance. They will drink 1,500 milliliters of fluid a day. They will relate need to replace fluids lost during exercise with sports drinks. And they will return to a normal hydration status and not develop hypovolemic shock. Goals for children may include that the parents will relate strategies to prevent dehydration. Parents will describe appropriate home management of fluid replacement for vomiting and diarrhea. And that's again like we talked about with the small amounts of fluid every 10 to 15 minutes. And that is recommended by pediatrics as well, the pediatricians. Parents will describe when to seek health care if the child conditions worsen instead of improving. Implementation. Recording intake and output accurately is important. Hourly intake and output may occasionally be indicated. You'll see that a lot in the intensive care unit. Weighing the client daily with the same scale and the same or similar clothing. Young children should be weighed without clothing. You also want to compare past weight and calculate their weight loss. Take vital signs. Monitor their central venous pressure, peripheral pulses, the peripheral pulse volume, so how strong it is, at least every 4 hours. Administer and monitor intake of fluids as prescribed. Administering intravenous fluids using an electronic infusion pump is going to be important. That way you can monitor how fast or slow that these fluids are administered. You want to monitor lab values, specifically electrolytes, BUN and creatinine, osmolality, urine-specific gravity. You want to monitor for changes in level of consciousness and mental status, making sure that you reposition them every 2 hours if they are unable to move independently. Instituting safety precautions to avoid falls. And that may be secondary to dizziness or loss of balance. You want to teach them prevention of orthostatic hypotension, so they need to change position slowly, avoid prolonged standing. They also recommend them resting in a recliner during the day as opposed to staying in the bed. Maintaining adequate fluid intake at approximately 1,500 milliliters per day. Prevention of fluid deficit, so you want to avoid exercising in extreme heat. Increase fluids in hot weather. Administer IV fluids as ordered. Take small sips of fluid. They do recommend flat cola or ginger ale. Ice chips may also be given. They need to decrease intake of caffeine, tea, and alcohol, which all increase their urinary output and can cause fluid loss. Evaluation of fluid volume deficit and dehydration. Expected outcomes may include the client has water and electrolytes that are balanced in intracellular and extracellular compartments as measured by serum electrolytes, hematocrit, and assessment findings. Client's urinary output is within normal limits. Client has adequate fluid intake to meet maintenance needs. Client's vital signs are within normal limits. Looking at fluid volume excess. Both water and sodium are retained in the body. This could be caused by fluid overload, which is being excess water and sodium intake. It could also be from an impairment of mechanisms of homeostasis that leads to hypervolemia, which is an excess in intravascular fluid, and edema, which is excess in interstitial fluids. And so in fluid volume overload, they have an increase in water. All right, looking at the pathophysiology of fluid volume excess, it is also called saline excess or extracellular volume overload. So fluid volume excess occurs when there's too much fluid in the extracellular compartment, and that is in your vascular and interstitial areas. Interstitial fluid volume excess, this results in edema. They will have abnormal increases in their interstitial fluid. Various conditions are associated with interstitial fluid volume excess, and that is increased blood hydrostatic pressure. So basically, when fluid volume excess occurs, the increased fluid volume in the vascular compartment congests the veins. The pressure against the capillary sides increases, and more fluid enters the interstitial compartments. In decreased blood colloid osmotic pressure, any condition that decreases plasma proteins will decrease the blood colloid osmotic pressure. Increased interstitial fluid osmotic pressure, this is when large amounts of protein enters the interstitial fluids, which causes this increase in interstitial fluid osmotic pressure. blocked lymphatic drainage. It's when lymph vessels are blocked, fluid accumulates in the interstitial compartments. Fluid volume excess results from conditions that cause retention of sodium and water. A little bit more of the patho of fluid volume excess. Remember, it's also called saline excess. They will have an increase in total body sodium content, and this causes an increase in total body water. Remember, water and sodium are always following each other. Because this increase is isotonic, the serum sodium and osmolality remain normal, and excess fluid remains in the extracellular spaces. All right, so causes could be heart failure, cirrhosis of the liver, renal failure, adrenal gland disorders, corticosteroids, and stress. Risk factors: decreased cardiac reserve or decreased cardiac output. Older adults are at greater risk for fluid volume excess, and that is because the natural reduction in kidney function occurs as we age. Abnormally increased fluid volume in pregnancy, such as seen in preeclampsia and heart disease. Other risk factors could be kidney dysfunctions, diabetes with peripheral vascular disease, hypertension, which impairs blood flow to the kidneys, IV therapy, so you want to make sure that you're monitoring the rate and type of solution being used. Your manifestations of fluid volume excess include a weight gain of greater than 5% of their body weight. This is over a short period of time. Circulatory overload causes full bounding pulses, distended neck and peripheral veins, increased central venous pressure, cough, dyspnea, and orthopnea. Manifestations of circulatory overload will include moist crackles, and if severe, it will progress to pulmonary edema. They will also have polyuria, ascites, which is fluid around the abdominal area, peripheral edema, or if it's severe, anasarca, which is generalized edema over the entire body. They will have decreased hematocrit and BUN, cerebral edema, and heart failure. All right, and so sometimes they will have to do a thoracentesis with ascites if it gets too bad. If they have lots of fluid that accumulates in the lung, they may have to do a thoracentesis. Paracentesis for ascites and thoracentesis for fluid in the lungs. All right, looking at collaboration, diagnostic tests that are ordered are going to be serum electrolytes and osmolality. Your serum sodium and osmolality are usually within normal limits, which we had already talked about. Serum hematocrit and hemoglobin are often decreased, and that's because they are diluted with all the excessive fluid. Renal tests are done to check the BUN and creatinine. Liver function test to assess the liver. Your pharmacologic therapy, there are three major classes: loop diuretics, thiazide type diuretics, and potassium sparing diuretics. Diuretics are often used because they can inhibit sodium and water reabsorption and thus increase urinary output. Fluid management. Some patients are actually put on fluid restriction. All fluid should be, intake should be calculated, including their meals, fluids that are used to administer oral medications or IV medications. Dietary management, they're going to be on a sodium restricted diet. Recommend that sodium intake be 500 to 2400 milligrams per day, and that is adjusted depending on what else is going on with your patient and how severe the fluid volume excess is. Fluid restriction guidelines, you want to subtract the required fluids from daily allowance, and this will be your IV fluids and fluids used to dilute your IV medications. The rest of the fluids should be divided between the shifts. So on day shift, they get about 50% of their total intake because they're going to get 2 meals, breakfast and lunch during that time. In the evening, they get 25 to 33%. And then on nights, they get the remainder of whatever wasn't consumed during the day. You also want to identify the client's preferred fluids and their intake patterns. So if they typically drink more at certain periods of time of the day, then you may adjust their fluid differently between the shifts. You want to place allowed amounts in small glasses because that gives the perception that the glass is full versus if you give them a big glass and don't put hardly anything in there. Ice chips, when melted, they are about half the frozen volume, so that'll kind of give you an idea of how much the ice chips count towards their intake. Frequent mouth care is going to be important because they're not drinking as much, and so their mouth's going to feel dry. Sugarless gum can also be used to help decrease thirst sensation. Nursing process, preventing fluid volume excess in clients that are at risk and managing problems resulting from the effects. You also want to monitor these clients that are receiving IV fluids for signs of hypervolemia. If that happens, you want to decrease the flow rate and promptly call the healthcare provider to report these symptoms of fluid overload. When you're getting a history, you want to assess risk factors such as medications that they're on, heart failure, acute and chronic renal disease, or endocrine diseases, precipitating factors like recent illnesses, changes in their diet or medications, any recent weight gain. You're also going to assess history of a persistent cough, which could indicate fluid in their lungs, shortness of breath, swelling of their feet and ankles, any difficulty sleeping when lying down, which is known as orthopnea. Physical assessment, daily weights should be done, same scale, same time, and same clothes. Vital signs, assessing peripheral pulses, capillary refill, and jugular vein distension. You want to assess for edema. This should be done even on your focused assessments. You want to check for edema by placing pressure on the skin over the tibia, behind the medial malleolus, and dorsum of the foot at least 5 seconds. If present, then you want to grade your edema as +1 for mild all the way up to +4 for severe. You also want to assess for periorbital edema, which is edema around the eyes. In men, assess for scrotal edema because that is the area that is dependent when they're sitting or lying in the bed. You want to assess lung sounds for crackles or wheezes, assess for dyspnea, cough, and any sputum present. Assess urinary output. For infants, they will weigh diapers to gauge their output. Also assessing mental status. A potential complication of fluid volume overload is pulmonary edema and ascites. All right, these are your NANDA diagnoses for fluid volume excess. When you're looking at planning, goals may include that the client will regain fluid balance, have clear lungs with eupneic breathing, which is normal breathing, maintain their skin integrity, tolerate increased levels of activity, make appropriate food choices to limit sodium. Implementation, again, daily weights, maintaining I&O records, administering oral fluids carefully, providing oral hygiene every 2 hours. You want to teach your patients about sodium restriction in their diet, administer diuretic medications and monitor their response, and then report any significant changes in serum electrolytes and osmolality. You want to teach your client medication safety so that they can administer their medication safely at home after discharge. Again, reminding them to reposition every 2 hours, reduce skin shearing or friction, provide alternative low-pressure mattresses, foot cradles, and heel protectors. That also helps to decrease pressure on these bony prominences. Position them in a Fowler's position. This is especially important if they have dyspnea or orthopnea. You wanted to monitor their oxygen saturation, ABG results, and if possible, elevate the area of edema. Evaluation. Some of your expected outcomes can include that the client maintains fluid balance as evidenced by lack of edema and laboratory diagnostic test. Client is able to participate in desired activity, and they maintain skin integrity. So looking at electrolyte imbalance, serum electrolytes values provide information about the concentration of electrolytes in the blood. Electrolytes normally are gained and lost in relatively equal amounts so that the body remains in balance. Abnormal route of loss, that could be from vomiting, diarrhea, diuretics, wound drainage, nasogastric suctioning, creates an uneven balance. All right, you want to monitor for signs of imbalance. Is important for your at-risk clients. Some of your signs can be very subtle. In moderate to severe imbalances, this produces multi-system effects and can lead to death if it's not reversed. Nurses must understand interactions among electrolytes and that imbalances rarely occurs in only one electrolyte. So looking at sodium, this is the most abundant electrolyte in the extracellular fluid. It assists in maintaining osmotic pressure and acid-base balance. Aldosterone assists in regulating the serum sodium balance as well. And sodium balance is affected by food intake. And most Americans consume a lot more sodium than needed to maintain a sodium balance. Hypernatremia is serum sodium levels greater than 145 milliequivalents per liter. Your critical values are greater than 160, and it is managed with fluid replacement at a moderate rate. And we'll talk a little bit more about hyper and hyponatremia in just a minute. Hyponatremia is a serum sodium levels of less than 125 milliequivalents per liter. Critical values are less than 115 milliequivalents per liter and is managed with sodium-containing food or fluid. All right, so in hyponatremia, this is when the cells become swollen. It's your most common electrolyte imbalance and can be caused by inadequate fluid intake. That could be from fasting diets. Could also be from excessive water gain, so they have decreased sodium concentration, and they have excessive hypotonic IV fluids can also cause hyponatremia. They may have increased in sodium excretion through diuretics. It could also be from Skin loss through burns and wound drainage. Could be from a GI loss with diarrhea, vomiting, draining fistulas, or nasogastric suctioning. Dilution of serum sodium from excessive water. Your syndrome of inappropriate antidiuretic hormone is your SIADH. Congestive heart failure and hypoaldosteronism are also causes of hyponatremia. And a lot of times with hyponatremia, they are in a fluid volume overload or excess state. All right, some of your clinical manifestations. They will have central nervous system changes, lethargy, confusion, irritability, seizures, and coma, dry mucous membranes, and headache. They may have postural hypotension and tachycardia with a thready pulse, cool, clammy skin. May have muscle weakness, nausea, vomiting, diarrhea, abdominal cramping, hyperactive bowel sounds. Some of your signs and symptoms of hyponatremia may not be evident until their levels are less than 125. So management, you want to check 24-hour intake and output, daily weights, checking their urine specific gravity. Less than 1.010 is very low, so the urine looks about as clear as water. Check for those bounding pulses and bulging neck veins. Check for blood pressure and respiratory changes. Assessing their sensorium, which is neuro status. Looking for signs and symptoms of cerebral edema. Check for pitting edema with fluid excess. Severe symptoms would cause seizures. You want to give small amounts of IV hypertonic saline, which is a 3% normal saline or sodium chloride. You have to be very careful giving this, and that's why they say small amounts, because you can actually change things very quickly and get things in hypernatremic state. Abnormal fluid loss is treated with fluid replacement with sodium-containing solution. Your hypernatremic causes, this is when the cells shrink. This could be from water deprivation, increase in sodium intake, excessive loss of water through diarrhea, an increase in the insensible loss, which could be from sweating, or prolonged fever or diaphoresis. Diabetes insipidus is a decreased response to antidiuretic hormone, can result in profound diuresis that results in water deficit and hypernatremia. So they end up with polyuria and polydysmia. Your hyperaldosteronism is a hypersecretion of aldosterone, which causes sodium and water retention. Cushing's syndrome is excess corticosteroids, such as prednisone. ACTH, which is adrenocorticotropic hormone secreting tumors. Hypernatremia is not as common as hyponatremia. Hypernatremia is not a problem in an alert patient that has access to water and can sense thirst and is able to swallow. Hypernatremia secondary to water deficiency is often a result of impaired level of consciousness or an inability to obtain fluids. And some people may fast for religious purposes that put them at risk for hypernatremia. Some of your manifestations in your CNS, you'll see restlessness, lethargy, agitation, seizures, muscle twitching or tremors, hyperreflexia, and a coma. They will have intense thirst, dry, swollen tongue, sticky mucous membranes, flush, dry skin, postural hypotension, and increased body temperature. So hypernatremia is usually from a fluid volume deficit. And so this is an acronym to kind of help you with some of your signs and symptoms. I was talking about you are fried, and so they use the FRIED to give you those symptoms. And this is another acronym called the model. And so they use MODEL. And these are treatments of hypernatremia. These are causes of increased serum sodium. And so medications, that could be your corticosteroids, some of your antibiotics, and sodium-containing parenteral solutions. It could be from meals, from too much sodium intake. You've got your osmotic diuretics, diabetes insipidus, excessive water losses, or low water intake. Hypernatremia, serum sodium levels must be reduced gradually because if you decrease them too fast, you can actually cause cerebral edema. Treatment is based on treating the underlying cause, and the goal of treatment is to dilute the excess sodium concentration with sodium-free IV fluids. And so you've got, if oral fluids cannot be ingested, IV solutions of 5% dextrose in water or a hypotonic solution is given gradually. And so basically, remember, the body metabolizes the dextrose and leaves only water, which is hypotonic in the body, but it's isotonic in the bag. Diuretics are given to promote excretion of excess sodium. Important thing to remember is sodium follows water. Nursing management. Check in 24-hour intake and output, daily weights. Urine specific gravity is usually greater than 1.025, so it's a lot more concentrated. Check for thready pulses, flat neck veins, skin turgor, and mucous membranes. Also assess for tachycardia, tachypnea, and check for changes in sensorium, which is neuro changes. Next electrolyte imbalance is potassium. It is an intracellular cation. About 98% of potassium is found within the cell. Plays a role in cellular depolarization and repolarization. It is a component of the potassium pump. It assists in moving potassium into a cell while sodium moves outside of the cell. Remember, that's that sodium-potassium pump we talked about earlier. All right, so hyperkalemia is serum potassium levels greater than 5.3. Critical values are approximately at 7. It is managed with administration of calcium gluconate, insulin and glucose, and K-exolate. Hypokalemia is a serum potassium level of less than 3.5. Critical values of potassium are less than 2.5, and it is managed with replacement of potassium salts. So causes of hypokalemia: they have abnormal losses from the body that could be through thiazide and loop diuretics, vomiting, diarrhea, NG suctioning, laxative, steroid use, and sweating. Magnesium depletion can also cause hypokalemia because magnesium and potassium go together. And so a lot of times there's that direct correlation between low potassium and low magnesium, because low magnesium levels will stimulate the release of renin, which causes an increase in aldosterone levels and excretion of potassium. So DKA, metabolic alkalosis, and pernicious anemia are also causes. Poor intake, and this could be from anorexia, alcoholism, depletion of potassium in the diet. It also could be from neglect. All right, so manifestations are going to be fatigue, weakness, leg cramps, fatigue, shallow respirations, hyporeflexia, which just means their reflexes are hypoactive. They may have a weak, irregular pulse, polyuria, which makes them have dilute urine, GI manifestations are going to be anorexia, nausea, vomiting, diarrhea, decreased GI motility, paralytic ileus, hypoactive bowel sounds. Endocrine, it can impair the release of insulin that leads to hyperglycemia. Also, with hypokalemia, they will have an enhanced digitalis effect. And so hypokalemia enhances the actions of digitalis, so you need to monitor them for signs of dig toxicity. Other manifestations are going to be your ECG changes. Some of the things that you'll see with low potassium are going to be flattened T waves, ST segment depression, frequent PVCs, bradycardia, a prominent U wave, and prolonged PR segment, which this picture shows you some of those. And this shows you some other waveforms that you will see with hypokalemia on the top. At the bottom, it's got your hyperkalemia, which we'll talk about in just a minute. So treatment, potassium chloride supplements can be given orally or IV. IV potassium should always be given diluted. It should never be given IV push because it can be fatal. Your IV potassium is usually in 20 to 40 milliequivalents per liter. It should not exceed 10 to 20 milliequivalents per hour, and that is to prevent hyperkalemia and cardiac arrest. Your IV potassium may cause pain at the area in which the vein is administered, so you want to monitor for any signs of phlebitis or infiltration. Potassium is very irritating to the veins. You have to have continuous cardiovascular monitoring if more than 40 milliequivalents per liter IV are given. You want to assess for signs of hyperkalemia and assess for patients that are taking PO potassium for GI upset. Again, monitor them for dig toxicity. Another treatment is increasing the potassium in the diet, and this could be through raisins, prunes, bananas, potatoes, tomatoes, fruits, etc. We talked about foods that contain potassium in the other lecture. Your hyperkalemic causes are from excess potassium intake. That could be from excessive or rapid parenteral administration, potassium containing drugs. There is a potassium containing penicillin. There are potassium containing salt substitutes. High potassium levels are very life-threatening. Your critical high 6.4 to 7. Renal failure is going to be your most common cause of hyperkalemia. Shifts of potassium out of the cells could be from acidosis, tissue catabolism, which is from fever, sepsis, burns. Crush injuries are also a cause. Tumor lysis syndrome, failure to eliminate potassium, acute or chronic renal failure, especially your patients on dialysis are at risk. Diabetic ketoacidosis, trauma, burns, medications, NSAIDs, beta blockers. Those are the ones that end in OLOL, like atenolol. Your ACE inhibitors, those are the ones that end in pril, like captopril. Your potassium sparing diuretics, which is aldactone. It's also known as spironolactone. All right, here's another acronym machine, and this is from causes of hyperkalemia. And so a lot of these we just talked about, but this will help you in remembering some of the causes of hyperkalemia. All right, manifestations. Irritability, anxiety, and paresthesia, which is numbness or tingling of the face, tongue, feet, or hands. They may have abdominal cramping, nausea and diarrhea, muscle weakness in the lower extremities, your cardiovascular issues, slow, irregular heart rate, EKG changes. They may have a tall peak T wave, prolonged PR interval, ST segment depression, loss of a P wave, widening QRS. So here is examples. In A, that shows a normal ST T wave. In B, that shows the T wave is peaking, which is the earliest change in hyperkalemia. In C, the T wave becomes taller and more peaked. It almost looks like the Eiffel Tower, which is why that picture is there. So it's tall peaked with a narrow base. In contrast, the T wave that is sometimes seen in healthy adults is in that lower right box that says normal variant, in which the T wave is rounded and its sides are not symmetric and has a broader base. In panel D, that shows the P wave amplitude decreases, the PR interval lengthens, and the QRS widens. In panel E, that shows the P wave disappears, they're in a sinoventricular rhythm, and the QRS becomes sinusoid, and VFib usually follows. And so as these progress from B all the way to E, that is the change that you will see with increasing levels of potassium. All right, and then here is a couple of other strips, as well as an EKG that shows hyperkalemia. All right, so hyperkalemia, they give you another acronym, murder, and this is signs and symptoms that you will see for hyperkalemia. And the reason why they call it that is because it is very, hyperkalemia is a lot worse on the heart and causes more issues than hypo. Both are not good as far as EKG changes, but more deaths occur from hyperkalemia. All right, treatment. Eliminate oral and parenteral potassium intake. You want to increase the elimination of potassium. That could be through diuretics that promote the excretion of potassium. You want to monitor their urinary output and their lab work. Dialysis can be initiated if the patient is in renal failure. Electrolyte is an ion exchange resin. It exchanges sodium ions for potassium ions in the intestine and excretes potassium via the feces. Increased fluid intake can enhance renal potassium elimination as well. Forcing potassium from extracellular fluids to intracellular fluids is done with IV insulin and IV dextrose. And so the IV insulin pushes potassium from extracellular to intracellular. It is given with glucose to prevent hypoglycemia. The effects start within 30 to 60 minutes. So this is a short-term fix, but not a permanent fix. So a lot of times they'll give them that first and then follow up with Electrolyte, which is a permanent fix for hyperkalemia, but it takes a little bit longer to take effect. IV sodium bicarbonate is given if hyperkalemia is secondary to acidosis as the cause. Reversing membrane effects of increased extracellular potassium is IV calcium gluconate. It can be given immediately to the patient that is experiencing cardiac arrhythmias that are secondary to life-threatening potassium levels. The effects start within minutes, but it only lasts an hour. So again, that is just a temporary fix. So you're going to have to follow through with something more permanent. All right, you want to caution patients to avoid foods that are high in potassium. And you can see coffee, chocolates, tea, dried fruits, and beans. your meats, eggs, bananas. All right, the next electrolyte we're going to talk about is chloride. This is the most prevalent in extracellular fluid. It is found with sodium, and together they maintain electricity of the body in a neutral state. It is also found with hydrogen to form hydrochloric acid in the stomach to aid in digestion. So that's your gastric acids. And it also plays a role in acid-base balance. All right, so looking at high and low levels of chloride, this could be caused by renal failure, overactive parathyroid glands, metabolic acidosis, and respiratory alkalosis. Hyperchloremia is a chloride level of greater than 105. Manifestations of hyperkalemia could be Kussmaul's respirations, weakness, and increased thirst. It is managed with diuretics, IV fluids, and treatment of the underlying cause, as well as dialysis. Hypochloremia is caused by loss of body fluids, especially vomiting and diarrhea. So these will be serum chloride levels of less than 95. Manifestations of hypochloremia are paresthesias of the face and extremities, muscle spasms, and tetany. Management is with increased salt in the diet, adding chloride to IV fluids, and treating the underlying cause. All right, calcium is the next electrolyte, and it has several major functions, including neuromuscular transmissions, controlling muscle contractions. It helps with blood clotting, helps with bone and teeth formation. It also helps with cellular membrane functioning. Calcium levels are controlled by vitamin D, calcitonin, and the parathyroid hormone. Hypercalcemia is serum calcium levels greater than 11 milliequivalents per liter. It is managed with partial parathyroidectomy, discontinuation of thiazide diuretics, vitamin and mineral supplements, and low calcium diet. Hypocalcemia is serum calcium levels less than 19 milliequivalents per liter. Severe symptoms are managed with IV replacement of calcium at a moderate rate. So your causes of hypocalcemia, and you see my levels are a little bit different than theirs, depending whether you're talking about total calcium or subtotal calcium levels. So low serum calcium levels can be caused by malignancy, vitamin D deficiency, decreased dietary intake, increased dietary phosphorus intake, such as antacids. And remember that calcium and phosphorus have an inverse relationship. So if their diet is high in phosphorus intake, then that's going to make the calcium levels low. It could also be from multiple blood transfusion, removal of the parathyroid gland, which we talked about when we talked about a thyroidectomy. Sometimes it can be inadvertently removed, or sometimes it's removed on purpose. They may also have a decrease in the parathyroid hormone production, and diuretics is also a cause. Manifestations are going to include tetany, positive Chebok-6 sign, positive Trousseau sign, which we talked about before. And we talked about tetany being characterized initially by numbness and tingling of the nose, ears, and fingertips, which is known as paresthesia. It can also progress to painful muscle spasms and convulsions. They will have hyperreflexia, so overactive reflexes. Laryngospasms can cause laryngeal stridor. And so that is something that you need to address very quickly and let the physician know. Arrhythmias is another life-threatening problem. This could result from V-fib. They may have torsades de pointes, which is a prolonged QT interval greater than 0.48 seconds. They may also have prolonged ST and, again, QT intervals. Decreased cardiac contractility and decreased blood pressure are also causes. The ones with a single star are going to be your more common findings, and the ones with a double star are your life-threatening ones. And so again, this is the cheek, that's your positive Chvostek sign, and Trousseau is the blood pressure cuff on the arm that causes those carpal spasms. All right, so other manifestations that you may see are going to be irritability, depression, confusion, anxiety, abdominal cramps, hyperactive bowel sounds. They may have excessive bleeding and bruising because hypocalcemia can cause clotting problems because calcium is needed to convert prothrombin into thrombin and fibrinogen into fibrin, which aids in clotting. So without calcium, fibrin stands and clots can't form, which allows excessive bleeding from venipunctures or other wounds. You will also see hyperactive reflexes and a prolonged ST segment. So these is an acronym of CATS that gives you your some of your major signs and symptoms of hypocalcemia. So treatment, you want to treat the underlying cause. So non-acute hypocalcemia can be treated with oral calcium carbonate, with vitamin D. They may also need to give magnesium if those levels are low as well. They can also use IV calcium, and that's usually in emergency treatment scenarios. So calcium gluconate or calcium chloride given slow IV push over 0.5 to 1 milliliters per minute. If you give it too fast, it can cause a rapid drop in blood pressure, arrhythmias, and cardiac arrest. It is not given IM because that causes local reactions. And if you give it IV, you need to watch for tissue necrosis. It is very harmful to the tissues. Treat pain and anxiety to prevent hyperventilation-induced respiratory alkalosis. All right, your hypercalcemia causes. Higher serum calcium levels can be caused by hyperparathyroidism, which is found in 2/3 of the cases, malignancy, vitamin D overdose, prolonged immobilization. This is the funny to break up the lecture. All right, manifestations: anorexia, nausea, fatigue, confusion, personality changes, constipation, dehydration, bone pain, and kidney stones. Treatment is going to be excretion of calcium with loop diuretics, hydration with isotonic saline infusions that will help flush the calcium out. Excretion of calcium is followed by excretion of sodium. Remember, they kind of go together. You want to monitor their intake and output, vital signs, monitor for muscle weakness and heart rate and rhythm. There is also a synthetic calcitonin that can be used, and also mobilization, just to get things working a little bit better and as far as secretion. All right, phosphate is the primary anion in intracellular fluid, normal levels 2.5 to 4.5. Functions are deposited with calcium for bone and tooth structure. It helps to metabolize proteins, carbohydrates, and fats. Also helps in acid-base buffering because it binds with hydrogen, which occurs primarily in the urine, making it the primary urinary buffer. It is essential to muscle, red blood cell, and nervous system function. It's important for maintenance of normal phosphate balance, requires adequate renal functioning because the kidneys are the primary route for phosphate excretion. Remember that calcium and phosphate have an inverse relationship. Just like calcium needs vitamin D for absorption in the GI tract, so does phosphate. So phosphate is involved as the primary constituent in the mitochondrial energy production of your adenosine triphosphate, which is your ATP. Note that phosphate is the part of the word, triphosphate. So ATP is used as an energy storage medium for the body. So causes of hypophosphatemia are going to be malnourishment and malabsorption, alcohol withdrawal. Could be from increased excretion through renal failure, hyperparathyroidism, or use of phosphate binding antacids such as aluminum, magnesium, or calcium antacids. Could also be from vomiting and diarrhea. Manifestations are going to include confusion, seizures, coma, memory loss, lethargy, irritability, and anxiety, respiratory problems, difficulty speaking, weakness of the respiratory muscles, and lethargy. You may have weakness in muscles, joint stiffness, tremors, fingertip numbness. May also have problems with anemia, bruising, and bleeding. They will have decreased deep tendon reflex, decreased bone density, fractures and alterations in bone shape. And so there is such thing as a hypophosphatemic rickets. And so that's what causes those deformities in the legs because the bones are deformed. Treatment is through oral supplementation, ingestion of foods high in phosphorus, IV administration of sodium or potassium phosphate. You want to make sure that patients are on a cardiac monitor during IV infusion due to the increased risk of arrhythmias. You also want to monitor their IV site, give it very slowly, and make sure it's diluted well. Safety measures for seizures need to be put in place. Monitor them for bleeding and respiratory failure. So you're wanting to watch for signs of hypoxia. And so your patients that are on ventilators are going to be at higher risk for hypophosphatemia. Hyperphosphatemia causes could be from acute or chronic renal failure, excessive ingestion of phosphate or vitamin D, hypoparathyroidism, excessive laxative use that contains phosphorus. Fleet's enema is an example of that. Manifestations are going to be tetany, twitching of muscles, especially in the hands and feet, hyperreflexia, you've got your positive Chavoxics and Trousseau signs, tingling, paresthesia, and muscle weakness, nervousness, irritability, anorexia, nausea, vomiting, and tachycardia. So you can see with this tetany and positive Chavoxics, Trousseaus, and hyperreflexia, how those are the same signs and symptoms that we saw with hypocalcemia. And remember, hypocalcemia usually accompanies hyperphosphatemia because they're the opposites. Management is to identify and treat their underlying cause, restrict foods, fluids, and laxatives that contain phosphate. Make sure they have adequate hydration and correction of hypocalcemic conditions. You want to administer aluminum-based antacids. Amphigel is an example. These bind with phosphorus in the GI tract, and then phosphorus is eliminated in the feces. Magnesium is the next electrolyte we'll talk about. 50 to 60% is contained in the bone. Normal levels 1.5 to 2.5 milliequivalents per liter. Their functions, as you can see, activates enzymes for metabolism of protein, carbohydrates, potassium, and calcium. It is a cofactor in the clotting cascade. It helps activate B complex vitamins, promotes muscle activity, and maintains strong and healthy bones. Causes of hypomagnesemia is going to be malabsorption problems such as inflammatory bowel disease, gastric bypass, alcoholics that are going through withdrawal. Glucose moves into the cell, pushing magnesium into the extracellular fluids where kidneys excrete it. Could also be from malnutrition, diarrhea, celiac disease, and Crohn's disease. Could be from an increased secretion through diuretics, insulin, amphotericin B, your aminoglycosides, which is like gentamicin, tobramycin, and neomycin, which are all antibiotics. Your nephrotoxic drugs, some of those are antibiotics, as well as your chemotherapeutic agents. Manifestations, they will have increased neuromuscular ability. That's secondary to hypocalcemia. So you can see we have some of the same symptoms: legs and foot cramping, tremors, twitching, positive oxyx, and Trousseau sign. EKG changes are going to be tall T waves, depressed ST segments. Cardiac arrhythmias, usually they're ventricular. You may also see AFib, premature ventricular contractions, and an increased heart rate. They may have difficulty swallowing. Usually they also have hyperreflexia as well. Mood changes you may see are going to be confusion, depression, psychosis, and irritability. You may see shallow respirations, decreased motility and bowel sounds, anorexia, nausea, abdominal distension, as well as seizures, tetany, and hyperreflexia. Hypomagnesemia management is going to be through oral substances, magnesium oxide tablets, Mylana, Tums. Increasing their dietary intake of magnesium. If it's severe, they can give magnesium sulfate IV. You want to make sure you give it very slowly, less than 150 milligrams per minute. If given too fast, it can cause sudden cardiac arrest. Potassium and calcium levels may need to be corrected as well. If the patient is put on digoxin, you want to check for toxicity, because remember, hypokalemia potentiates toxicity, and usually when they're low in potassium, they're usually low in magnesium as well. If the patient is on IV mag sulfate, you want to check for decreased patellar reflex, respiratory difficulty, and hypotension. These are all signs of mag toxicity, so you want to stop these, stop the infusion if these occur. Hypermagnesemia causes could be increased intake or ingestion of products that contain magnesium. That's usually antacids and laxatives. This is usually more so prevalent when renal insufficiency or failure is present. Hypermagnesemia is rare, and it's usually only seen in clients that have renal failure. So patients with diabetes mellitus and DKA, that may cause them to have a high magnesium level. Your patients with leukemia are going to be at increased risk due to nephrotoxic drugs, which would directly cause damage to the kidneys, that leading to renal insufficiency. And so that would be your acute lymphatic or myelocytic leukemias. Your magnesium-containing antacids are going to include Tums, Maalox, and Mylana. The laxatives could be Epsom salt, milk of magnesia, citrate of magnesium. Manifestations: muscle twitching, hyperreflexia, diaphoresis, hypotension, bradycardia, dysrhythmias, a prolonged PR or widened QRS, peripheral vasodilation, decreased deep tendon reflexes, flushing, decreased loss of consciousness, and respiratory depression. Management, prevention is going to be the most important thing. For people with compromised kidneys, dialysis is done to get rid of the high magnesium levels. You want to teach them to avoid magnesium-containing foods and drugs. With healthy kidneys, emergency treatment can be through IV calcium chloride or calcium gluconate. You want to increase fluids to promote urinary excretion of the magnesium. Diuretics may also be used. They will be needing long-term or continuous cardiac monitoring because often their potassium level will increase. So you want to report prolonged QT intervals, wide QRS complexes, or the presence of an AV block. Monitor their intake and output. You also want to assess their neurostatus for mental status changes and their reflexes, looking at deep tendon reflexes. You want to report if there's any absence in these deep tendon reflexes, especially the patellar, or a decrease in level of consciousness. All right, so nurses need to have a good understanding of the etiologies, signs and symptoms, and suggested treatments of both excess and deficiencies in specific electrolytes. So general assessment is going to include review of lab data for specific excesses or deficits, monitoring EKG, urinalysis, hemoglobin and hematocrit, monitoring their ABGs. The assessment is subjective data would be looking at abnormal thirst, frequent urination, anorexia or nausea, pain, muscle cramping, diarrhea. Objective data is going to include vital signs, mental status examination of deep tendon reflexes, presence of diarrhea or vomiting, heart and lung sounds, assessing for edema. These are your NANDA diagnosis for electrolyte imbalances. Planning goals may include that your client will maintain electrolyte levels within normal limits, be free of symptoms of electrolyte or acid-base balance, maintain regular heart rhythm and output. Implementation, monitoring sodium, potassium, chloride, magnesium levels daily. These will be monitored more often if they have significant elevations or decrease in these electrolytes. You also want to monitor their intake and output as directed by the agency policy. Observe for signs and symptoms of dehydration. Also looking for signs and symptoms of fluid and electrolyte excess or deficiencies. Evaluation. Expected outcomes may include client's electrolyte status returns to appropriate levels as evidenced by normal serum electrolytes, normal urinalysis, and absence of edema. The client maintains appropriate weight for their age and height, and the client maintains equality of intake and output as evidenced by direct measurement or via journals that they may have kept at home as far as their intake and output. All right, so this includes your fluid and electrolyte imbalances, and as always, please let me know if you have any questions, and we probably all feel like this tiger after this fluid and electrolyte stuff.